So let's just talk about the things that I'm going to consider to be the more modern or the more progressive therapies. So we're going to focus on the 23s, and we've mentioned the 17s just a little bit as being things that we've talked about. So newer biologic options, particularly 23. Let's mention tildrakizumab. So anyone using that besides
I
me?
have not
Yes.
used it,
Okay.
but I think Douglas
have?
has.
Yeah, I've got
Why
some
do you pick
patients.
that?
Well, I pick it because I've picked all of them. I mean, some of it. I mean, just to be quite honest with you, when you see a lot of patients and you get known as a person who is aggressive with psoriasis and has success with it and spends time with patients, then more people come to you. And so when new medicines come out, I'm going to give them a try, particularly if I look at the data and see that it's got good safety. So, but the question is, we have now 3 IL-23s out, and tildrakizumab, it went into development ahead of the others, but it was slower to come out. I mean, it was a pretty slow rollout for them, because really Tremfya or the guselkumab was really the first to come out, and it came out in 2017, approved for moderate to severe psoriasis for us. So that was the first one out when Tremfya came, and it was nice because it continued the dosing regimen of Stelara. And it was focused on IL-23, but it didn't. You had to give it at 0, 4 weeks, 0 weeks, 4 weeks, and then Q8. So it wasn't quite as long as, but it still wasn't a bump for patients to have a big transition to it. The tildrakizumab, I've had pretty good success with. I've had success with all these. When we compare all of these products to placebo, they're extraordinarily better than placebo. The problem with the tildrakizumab is just a little slower to get to where you want it to be. Because the way that Merck designed the trial when they owned the product is they put the primary endpoint at 12 weeks, where everyone else has put the primary endpoint at 16 in this new class. So they didn't have very robust data at 12 weeks. When they look at the data at 12 weeks, it's better, but really when they look at their data at 28 weeks is when it really starts to show that, hey, this is a product that should be considered in patients, because it's got great durability, it's got good safety on its side, and also it tends to be a product, tildrakizumab, that doesn't care about obesity. In other words, it doesn't matter how heavy patients were, they had the same response. So if you're looking at that obesity response. And the last thing I would say about tildrakizumab, which is I don't have as many on as I do the others, so I'm not trying to overly hype it, but some post hoc analysis with that particular product shows that it may help certainly improve, not to a statistical significance, but they saw a drop in systolic hypertension. They saw in systolic blood pressure. They saw a drop in fasting blood glucose, and they saw an overall improvement in metabolic syndrome in patients that were put on tildrakizumab. It's Ilumya. It's dosed at 0 weeks, 4 weeks, and then Q12 thereafter. Tremfya is 0, as I said, 4 and Q8, and then risankizumab is dosed at 0, 4, and 12 as well. You have to give two shots with the Skyrizi, the risankizumab, each time you dose it, and not the case for the other two. So there are some differentiators in that IL-23 class.
So there are a lot of similarities between amongst all of the 23s and a little bit of difference as well. And with the ustekinumab being the last therapy that we had that was weight-based, which is also known as Stelara, that the drugs that have come since that time with the 23s, the other 3 23s, the weight does not affect the dose. But the dosing schedule, as Douglas mentioned, all start with a dose 0 and then 4 weeks later, and then it's a matter of, do you redose it every 8 or do you redose at every 12? Some of them can be done at home, administered at home, and tildrakizumab is one of the ones that's still just to be administered within the office.
That's a point I didn't make.
It's done
delivered administered in the office.
Yeah, healthcare provider, and that can be a pro, and sometimes it can be a con. It's a pro for me because we have data as well that shows that regardless of what you're dealing with, the more intervention by the healthcare team, the healthcare provider, the better the adherence. Thus, the better the outcome that you're going to get from that therapy. So if you have a patient, and I have purposely put people on tildrakizumab because I did not want them dosing at home. for a lot of reasons. And sometimes it's because people start to get clear and then they start to push their treatments out and go, well, if I'm only dosed every 8, but I'm so clear, what happens if I skip a treatment or if I push it back, or they start sharing with their family friends? So there are reasons that would be good. And with risankizumab, with that has just come out, we also have the opportunity to dose in the office, and you might dose them for a while until you get them clear and then let them go. And then also with guselkumab, the same. You might dose them in the office to begin with. And my rule is, once you've been clear for a year, once you've been on therapy for a year, if home dosing is an option, it would be something I would consider.
Yeah,
but
I think that's important
you don't want to
differentiator between these, because also for those Medicare patients that the donut hole is a big problem. You can sometimes buy and bill and administer the Illumina in the office, or in our area, the local hospital at the infusion center allows us to send patients there and then be injected, so it's treated as a medical device. So that's a great advantage to it.